emphasize that patients present with complaints, not diagnoses. You know, there's only so much they can tell us. I mean, not every patient's a cardiologist. We're not cardiologists. Right? Most complaints are associated with more than just one kind of problem. So you've got to be able to use some clinical reasoning and critical thinking here. You've got to be able to kind of figure out and use a deliberate process to develop a develop a list of differential diagnosis, and then that helps guide your decision making about your care and transport. It's really important to just avoid jumping straight from a complaint or initial presentation to a diagnosis. You need to go through the process and develop a list of different things, what they could be. You know, when we're doing this information that we're getting and we're finding out during our history, our assessment, that initial presentation, all of this serves to kind of move your items on the list higher or lower, like what's more likely to be possible, what's more likely to be probable even. Okay, we want to include a lot of causes, not just cardiovascular, but we do need to include those cardiovascular. You need to be familiar with your different cardiovascular complaints, so that way you can do a thorough differential diagnosis. General approach here is going to be the same as most of your medical. We're going to do your primary assessment. You know, we're going to see if they're responsive, unresponsive, general appearance, observations of the scene. We're going to determine if there's anything else needed, any care needed. And then our unresponsive patients or patients with poor general appearance, keep in mind, you probably are going to require some immediate interventions that will need more than just you and or your partner. Okay, so we're going to start with ABCs, right? So with that primary assessment, you know, for responsive and unresponsive, it's going to be essentially the same. We're going to determine the adequacy of the airway, ventilation, oxygenation, and perfusion. If that patient's unresponsive and if there's no carotid pulse detected within 10 seconds, we start CPR, apply AED, maintain compressions, airway ventilations, BVM, and protocols for resuscitation, transport, etc. Right, if they are responsive with a poor general appearance, they're going to need immediate assessment for signs of a compromised airway, inadequate ventilations, hypoxia, or poor perfusion. We're going to treat those problems before we move on to any further history or secondary assessment. We have to treat those life threats when we find them. All right. For a responsive patient, further assessment starts with your chief complaint. So we're going, and for an unresponsive, it's going to be getting information from bystanders, your scene, things like that. Don't prematurely make your conclusions. Go ahead and do a thorough assessment and judgment based on what's going on and what you find. Right? You have to be able to determine a reasonably accurate field impression. If we cannot do this, then we may not know the proper treatments. For example, so let's say somebody has dyspnea, and that dyspnea is caused by COPD. Albuterol may be indicated. If the dyspnea is related to left-sided heart failure, then albuterol is not given in most cases, but other medications are. So not only, you know, if you make an incorrect assumption about their problem, it not only means that they get the wrong treatment, but it means they don't get the correct treatment. And sometimes that can be even worse. Right, so some of our chief complaints, our common chief complaints and associated complaints, kind of create this immediate suspicion of a cardiac problem. That would be chest pain and dyspnea, but those also should create kind of an immediate suspicion for respiratory problems. So our initial questioning is going to help identify which system is the underlying cause so that we know the appropriate management pathway to take. Okay, keep in mind though, the cardiovascular and respiratory systems are very much intertwined. So often when you have a problem with one, you may have a problem with the other. Okay, we may not always be able to determine an exact cause or underlying issue, which came first, the chicken or the egg, but we need to make sure that we identify what most likely problem is going on. Okay, so a reasonable place to start. Has this ever happened before? If they've experienced similar episodes in the past, then that can kind of help you direct your clinical reasoning process. Expand on their chief complaint, asking circumstances, your onset, what happened, what makes it better or worse, you know, quality, what does it feel like, the nature. If they have pain, does that pain move, radiate? You know, how severe is it? Scale of 1 to 10. 10 is zero pain. 10 is I'm cutting your fingers off with a rusty spoon. Where are we at on that pain scale? All right. For other complaints, it may be frequency of occurrence, how often those symptoms occur or affect the patient. For example, vomiting. If they have frequent vomiting, it may move the history in one direction, whereas an isolated episode of vomiting kind of keeps it in the cardiac realm. All right, ask them if they have any other symptoms. Keep asking them, is there anything else, until they have nothing else to offer. All right, if the patient does not mention any specific symptoms you might expect to hear in a patient with a similar presentation, ask about them. You're not going to put ideas in their head. Go ahead and ask them about them. Ask about their past medical history, and make sure that you have a full list, compilation of their medications that they take, and hopefully if they take them or not. All right, some other complaints that you will see with cardiovascular problems may be heaviness, pressure, a sensation of discomfort in the chest, a sensation of indigestion or upset stomach, heartburn, pain or discomfort in the abdomen, in the arm, the back, the shoulder, the neck, or the jaw. Abdominal pain and chest back pain can also be caused by an abdominal aortic aneurysm. They may complain of palpitations, nausea, vomiting. None of these are just specific absolutely to cardiovascular, but they all can occur with your cardiovascular complaints. So it's really important to do that good assessment and good history taking here. Patients can also present with syncope or altered mental status if it is severe enough. Sometimes patients even kind of come out of left field and have some weird or, some seemingly unrelated complaints like headaches, visual disturbances, things like that. But those can also be caused by acute hypertension, which goes back to your cardiovascular system. So there are a lot of different things here how this patient can kind of present. And then, of course, cardiac arrest. Cardiac arrest has a bunch of different causes. But most common cause of an out-of-hospital cardiac arrest is going to be VFib, secondary to ACS of some sort. So, what is ACS? I'm glad you asked. ACS is going to be an acute coronary syndrome. And what this does is, they can't really differentiate necessarily pre-hospital between all these things. So they have this umbrella term that kind of covers a bunch of different, and they all share the common pathway to insufficient oxygen demand to meet the heart's needs for oxygen. Right? When there's not enough oxygen, the myocardium becomes ischemic or damaged. Okay? It is hypoxic. The most common cause of this is coronary artery disease, which is a buildup of fatty tissues in the coronary arteries called atherosclerosis. This fatty tissue or plaque is going to decrease the amount of blood that can actually reach the myocardium. ACS also includes your unstable angina, acute MI, and sudden cardiac arrest. So atherosclerosis. With this, it's a kind of several different sequence of events that occurs, and it starts when you're fairly young. There's a lot of things that can contribute to it, okay, like inflammatory response, genetics, smoking, diabetes, and hypertension all can make it worse, but diet also is a really big part of it as well. So the first thing that's going to happen with atherosclerosis is disruption of the endothelium of the tunica intima. Remember, we've got your 3 layers of your vessels. So the tunica intima is the very inside portion. So when you have an injury and inflammatory response there, the intima is not going to act as a barrier between the blood components and the elastic tunica media. All right. So causes of injury and inflammation here can include cigarette smoking or cigar smoking, tobacco in general, elevated blood glucose levels, chronically elevated blood glucose levels, and increased blood lipids or fat levels, and of course hypertension. So the next stage, this damaged endothelial layer lets this fat from the bloodstream enter and accumulate in these tissues below the intima. And when these lipids are deposited like this, where they're not normally deposited, they're seen as kind of foreign invaders by the immune system. So the white blood cells go and absorb the fat and die, but they don't go away. They stay in your blood tissue. All right, and so this starts the kind of these little fatty streaks in the vessels. So after decades of this cell buildup, the smooth muscle begins to migrate from the tunica media to the tunica just below the intima. And the smooth muscle cells also start taking up lipids. When these smooth muscle cells take up too much lipids, it's called plaque. And when this plaque is there, that means the vessel the lumen cannot change as well. And it also narrows that lumen, which means you're not going to have adequate room for blood flow. Additionally, sometimes this plaque can rupture. And when this plaque ruptures, It's one of the leading causes of your AMIs, where you get that embolism that causes a blockage there. So angina pectoris, all right, is chest pain that occurs when the myocardial oxygen needs are higher than the amount of oxygen that the diseased coronary arteries can supply. Usually this pain is going to be retrosternal. It's going to be described as pressure or tightening, but it can radiate to the neck, the jaw, the arms, specifically more commonly the left arm. They may have nausea, vomiting, pallor, diaphoresis, dyspnea, all very similar signs and symptoms that can occur with an MI. All right, now, recurrent chest pain that only comes on during exercise or stress and is resolved with rest or nitro is called stable angina. All right, unstable angina occurs at rest or occurs with progressive frequency or worsening episodes of pain and is not relieved by rest within 20 minutes or 3 doses of nitro. All right, stable angina is caused by relative myocardial oxygen deficit, but unstable angina is an absolute decrease in oxygen supply from worsening atherosclerosis, all right, which puts that patient at a higher risk for your MI. And think of it like this. For stable angina, you go out, you cut your grass, your chest starts hurting, you come in, you sit down, you rest. Maybe you take 1 nitro, your pain's relieved, life goes on. All right, that would be stable. Next week you go out to cut your grass, your chest starts hurting. You come in, you sit down, you take your 1 nitro, it's relieved, you're fine. It's the same, nothing has changed. With your unstable, let's say now you're going outside, you cut your grass, your chest starts hurting, you come in, you take a nitro. Nothing. So you take another nitro. Nothing. It's progressing, it's different, it's worse than it was before. Okay, so that's going to be your unstable. Now your acute myocardial infarction, or AMI, or sometimes called MI. Alright, so whenever this fibrous plaque is going to rupture, the damaged blood vessel is going to start the clotting cascade, and which is going to further narrow or completely obstruct that artery. When that artery is obstructed, no blood flow happens, and your myocardial cells are deprived of oxygen, and they start to die. Okay, so that is an acute myocardial infarction. Alright, AMIs a lot of times are not actually triggered by stress or activity, but instead they occur at rest. And the pain is very similar to your angina pectoris. It may radiate to the shoulders, the neck, the jaw. If they have a history of angina, AMI pain is typically more intense than the usual pain and is not relieved by rest or nitroglycerin. Now, some of your signs and symptoms of your ACS. Okay, the classic response is going to be chest pain, right? But classic doesn't always mean that it happens in every response or every case. Some may describe the sensation as discomfort, an ache, a pressure. So it's better usually to ask open-ended questions like, how does your chest feel? What do you feel? If you use a closed-ended question, asking if they have chest discomfort, they may not consider the sensation that they are feeling or interpreting to be pain. All right? That discomfort is usually going to be retrosternal, but it could be right-sided, left-sided, all throughout the chest. Okay? Some even have pain in their back or flank or upper abdomen, and some may not have any pain or discomfort at all. Usually an ACS pain or discomfort is not likely to increase with palpation, but if you do provoke increased discomfort by palpating the chest or area, it doesn't necessarily rule out ACS as well. All right, and there are a couple of other signs or symptoms that can be present, or may not be present. Approximately 25% of your MI patients have silent MIs, which means they occur without signs or symptoms and are found on the EKG at a later date and time. All right, some of your typical signs and symptoms: cool, clammy skin, pale ashen appearance, diaphoresis, nausea, vomiting, lightheadedness or weakness, dyspnea, anxiety, arm, shoulder, back, neck, or jaw discomfort, lung sounds, often are clear. Your EKGs may or may not be normal. So whenever a patient experiences symptoms other than the chest pressure, those signs and symptoms are called anginal equivalents. And so what this means is chest pain that is sharp in character, pain in the back, arms, or jaw, abdominal discomfort or sensation of indigestion, nausea, vomiting, faintness, or fainting, actual syncope, and a feeling of weakness. And it's important to look for these because not all of your patient populations are going to present with your typical symptoms. Specifically, women, diabetics, and the elderly do not present more commonly with your common or more typical classic signs and symptoms. So be very suspicious for your atypical presentations there with those patients.